The case of an 82-year-old female patient who was brought to the emergency department, ED, presents a complex clinical scenario. Presenting symptoms: confusion, refusal to eat, low level of consciousness, GCS 13, low temperature, 35.8 C, low heart rate, 58 BPM, low blood pressure, 92/55 of a millimeter of mercury, respiratory rate of 22 BPM, SpO2 of 96% on room air, painful and distended abdomen without tenderness. Radiography findings: moderate colonic distension. Blood tests: leukocytosis, 14,400 per microliter, normal platelet count, elevated creatinine, 1.4 mg per deciliter, previously 0.9 mg per deciliter, and CRP of 2.7 mg per deciliter. Treatment: administration of laxatives restored intestinal transit. Additional findings: elevation of TSH and marked reduction of thyroid hormones, T3 and T4. Hormonal replacement: levothyroxine led to progressive improvement of neurologic dysfunction. CRP levels remained less than 5 mg per deciliter, and antibiotics were not prescribed. Sepsis consideration: according to the 2021 SSC guidelines, sepsis was considered possible, but the low level of CRP was against that suspicion. Today we will discuss how to use biomarkers of infection or sepsis at the bedside, a guide to clinicians. Biomarkers are used by clinicians to address several questions in the suspicion of sepsis. Questions include assessing the likelihood of infection, severity of illness, risk of developing septic shock, identifying likely pathogens, determining appropriate antimicrobial treatment, evaluating patient improvement, and deciding when to stop antimicrobials. Despite their use, it's vital to recognize that biomarker performance in sepsis management is suboptimal. 3 vectors of sepsis approach systemic manifestations. This refers to the general symptoms and signs that the body exhibits in response to sepsis, such as fever, increased heart rate, and altered mental status. Organ dysfunction. Sepsis can lead to dysfunction in various organs, such as the kidneys, liver, and lungs. This dysfunction can be assessed through specific clinical and laboratory findings. Microbiological documentation. This involves identifying the specific pathogens causing the infection, often through blood cultures or other laboratory tests. The definition of biomarkers is: biomarkers are biological characteristics, objectively measured, used as surrogate markers for physiological or pathological processes, or as indicators of drug activity. In the context of infection and sepsis, they can indicate infection, dysregulated host response, or response to treatment. First we will look into pathogen-specific biomarkers. Microbial nucleic acids, becoming more common but not yet well standardized in managing infections. Direct antigen tests, widely used in critically ill patients, with pooled diagnostic performance shown in Table 1. Rapid antigen-based tests, used for various infections like influenza, SARS-CoV-2, and pneumonia. They have high specificity but low to moderate sensitivity, and a negative test cannot be reliably considered a rule-out result. Legionella and pneumococcal antigen tests, specific issues with false negatives and dependency on serotype. Clostridioides difficile infection, CDI, diagnosis, utilizes a 2-step algorithm with rapid enzyme immunoassays. Fungal antigen assays, includes 1,3-beta-D-glucan, BDG, for invasive candidiasis and galactomannan, GM, for invasive pulmonary aspergillosis, IPA. Rapid diagnostic tests. Few tests like MARI-POC utilize multiplex testing, but none provide information about antibiotic sensitivity. Challenges. Issues with sensitivity, specificity, and overuse of antifungals in some cases. Role these pathogen-specific biomarkers in treatment. First, BDG-guided strategy, tested in RCTs for discontinuation of empirical antifungal therapy in critically ill patients, showing safety and reduction in the duration of therapy. Development and research. Ongoing research and development in rapid, bedside tests, and pathogen-specific biomarker-guided algorithms. We need more data to actively incorporate these things in our clinical bedside practice. Coming to host response biomarkers. First we will discuss procalcitonin, or PCT. Definition: PCT is a prohormone, the precursor of calcitonin, produced by almost all organs and macrophages. Its levels increase 3 to 4 hours after an inflammatory stimulus, peak at about 24 hours, and have a half-life of 22 to 35 hours. PCT levels are influenced by glomerular filtration rate and renal replacement therapy. Use in prediction of sepsis. Procalcitonin, or PCT, is a studied biomarker for ventilator-associated pneumonia, VAP. PCT measurements show limited utility in predicting or diagnosing VAP. Studies of PCT kinetics reveal poor diagnostic accuracy and low impact on therapy initiation. Despite links to decreased antibiotic use in some settings, PCT's utility to predict sepsis in the ICU is limited. Next is the role of PCT in diagnosis of sepsis. There is no agreed PCT cutoff value for sepsis diagnosis, with values ranging from 0.5 to 2 micrograms per liter. Non-infectious inflammatory states also associated with elevated PCT serum levels. Meta-analyses reveal sensitivity and specificity range of 77 to 85% and 75 to 83%. PCT may be superior to CRP in suspicion of sepsis but should not guide antimicrobial prescription. Guidelines do not recommend PCT for the diagnosis of VAP. In severe CAP, PCT has been evaluated for bacterial co-infection in influenza, but more studies are needed. Meta-analysis indicates PCT lacks sensitivity early during CAP. Next is for assessment of sepsis response to therapy, evaluation at 48 to 72 hours after diagnosis. In VAP patients, PCT levels can predict survival, differentiating outcomes. Persistent high PCT levels on D4 of antibiotic therapy indicate infection control failure. Alert PCT concept was evaluated but showed no mortality benefit. Guidelines include reassessing daily, using biomarkers and clinical course. Stopping antibiotics based on PCT and CRP decrease, 7 full days of therapy, or other conditions. PCT-guided antibiotic therapy, increasingly popular to use biomarkers to personalize antibiotic treatment duration. Confirms a reduction in overall antibiotic use with PCT. At least 18 RCT evaluating PCT-guided therapy found it safe and associated with shorter therapy duration, some with decreased mortality. A recent systematic review revealed PCT-guided strategy reduced antibiotic duration by 1 day and improved survival. C-reactive protein, CRP, in the next important biomarker. Its synthesis and level of CRP, synthesized in the liver, increases 4 to 6 hours after an inflammatory stimulus, doubling every 8 hours. Peaks at 36 to 50 hours, half-life of 19 hours. Not influenced by immunosuppression, renal failure, renal replacement therapy, or cirrhosis. Prediction of sepsis. CRP kinetics accurately predicted ICU-acquired sepsis. Maximum daily CRP increase greater than 4.1 mg per deciliter indicates sepsis. CRP and CRP slope are good predictors of VAP occurrence. Guidelines do not recommend biomarkers for VAP diagnosis. Next is role of CRP in diagnosis of sepsis. Sensitivity and specificity range from 78 to 80% to 60 to 61%. CRP found to be an efficient discriminator between sepsis and non-septic SIRS. High CRP levels predict CAP in cases of false negative chest X-ray. Low levels exclude CAP in false positives. CRP for assessment of sepsis response to therapy. CRP studied for response to therapy in VAP, BSI, CAP. CRP ratio, relative variations, found to be informative. 4 patterns of response to antibiotic therapy: fast response, slow response, non-response, biphasic response. Fast and slow response patterns have lower mortality. 2017 guidelines recognize value of biomarkers like CRP ratio. Finally, how to do CRP-guided antibiotic therapy. RCT assessing CRP-guided strategy are scarce in ICU. CRP found to be non-inferior to PCT for duration guidance. No substantial differences in CRP-guided strategy versus PCT-guided or fixed duration. Biomarker-guided strategies showed reduced antibiotic exposure. Individualized therapy combining fixed duration with biomarker guidance has been assessed in several RCT. This strategy can safely decrease the duration of therapy compared to fixed duration. How can we synthesize all that information? Let's first look at the combination of biomarkers. Combining various biomarkers for a diagnostic panel has not proven superior in diagnosing sepsis. Sepsis biomarkers are often highly correlated. Diagnostic accuracy hasn't improved with combination. Interpretation of biomarker panels can be either relatively sensitive or specific, based on the criteria. The next but more practical approach is algorithms with clinical data. Algorithms that combine biomarkers with clinical data show promise. An algorithm including clinical variables and biomarkers claimed a negative predictive value of 100% and positive predictive value of 93%. Limitations include unknown performance in SIRS-negative sepsis and unspecified result delivery speed. Before we share the take-home message, as we conclude our exploration into the complex world of sepsis biomarkers, it's clear that the journey towards precise and effective diagnosis is filled with challenges and opportunities. If you like our presentation, stay tuned for more insights and discoveries, and don't forget to subscribe for the latest updates in the medical field. The take-home messages are: a significant change in approach is needed to have clinically useful markers for sepsis. Large multi-center studies using modern techniques like omics, bioinformatics, machine learning are required. Collaboration across centers and disciplines is vital for discovering new biomarkers for clinical implementation. Until then, sepsis biomarkers are valuable as adjunctive tools. Serial determinations are more informative than single values. Biomarkers should always be used with a thorough clinical evaluation and an understanding of their biology, interferences, strengths, and limitations. CRP in place of PCT may be used in resource-limited setup, and algorithms can be made with clinical characteristics for more effective management of sepsis.